in our hub today, Dr. James Zulu, and also joined by our IT experts, Chatonda and Kote. We also have our ECHO coordinator, Madam Etta. And thank you so much for those that have joined us online across the country. We do have different people that we can take the whole day to mention, but I'll just take special mention of our experts that have joined on the call. We know we should have Dr. Mwanza, Dr. Mwamba, Dr. Silumbe, and also Dr. Sivile joining us as the subject matter experts. Thank you for joining us. I also just want to mention a few other people that have joined us this afternoon. Dr. Adamson Jobo, I know from Cowboy, thank you for joining us. And I know we also have some other people that have joined us from different provinces. Thank you very much for being with us this afternoon. And I hope you pick up some great lessons from this discussion today. And so as we begin our session, I just want to remind us of our rules for ECHO. Remember, each time that we are on online on such a Zoom meeting, we want to make sure that we keep ourselves muted and use the raising hand signal if you want to say something, and then you can be able to speak. Also, let's keep our videos. We can keep our videos on, and then also, if we can, that is, we can keep it on. But we just mind that if we're doing a lot of work and movement, we avoid turning on our videos. That being said, we want you to participate, and please do share your thoughts on the chat. So far, we've posted a link that you can use for registering. Please register through that link. If you are in one place, a number of you, like we have, I know I've seen the Mine Hospital. Thank you, Mine Hospital, for joining us. We appreciate your connecting with us. Are you able to hear us? Maybe we also want to hear from you. IT, help them unmute. Good afternoon, Mine Hospital.
Good afternoon.
Thank you for joining us. Thank you for joining us. I was just saying that when we register, please, all of us should be able to just click on that link and register everyone that is in that place. So thank you for joining us. We're hoping to hear from you as well. So that being said, I am going to now invite our guest for this afternoon to introduce himself, and then we can carry on with the presentation for today. Dr. Zulu.
Thank you very much, Dr. Zambo. I'm Dr. James Zulu. I'm in charge of the men's clinic initiatives. I work with CIDAS, and of course, giving the technical support to the ministry on the Global Fund, the SI program. So I'll be taking you through this afternoon. So as you can see, I have no significant conflicts of interest to disclose. These are the 4 learning objectives which we have. We want to review the unique health needs of men in Zambia, and then to understand what are some of the barriers and the challenges men have for not putting their health as a priority. And of course, want to understand and to review some of the strategies on how we are going to improve in terms of case findings in men. And then of course, we want to look at some of the few lessons and from the neighborhood in the region of reaching out to men. So maybe we can start by, we want to hear some of the experiences as a matter of a discussion from facilities you, the network, who are coming from various facilities, would like to hear from you. On a typical day of the week, like a Monday, Tuesday, Wednesday, Thursday, Friday, which gender is mostly at the facility seeking some medical attention? Which gender, what type of people, which gender do you normally have as a facility seeking medical attention? Maybe we'd like to hear from you.
Yeah, very, very interesting question, Dr. Zulu. Can we hear from the facilities which gender is quite more common on any particular day, on any given day that we see in our facility? Yeah, somebody has raised their hand. Anyone? Yes, Kakeza.
Good afternoon, Doc. Good afternoon, everyone. Thank you so much. On average, we mostly see women compared to men at facilities. Thank you.
Which facility?
Okay.
This is L85 Army Camp Hospital in Chiranga, Lusaka.
Oh, thank you very much for your comment. I've seen George Clinic. Can George Clinic make a comment as well? George Clinic.
Thank you. Mainly, the people that make visits at the clinic are females and children. Thank you.
Okay. We're doing random sampling. I've seen Mtanga wanted to say a comment. Please go ahead, Mtanga.
Yes, good afternoon, everyone.
Yes.
Actually, mostly we normally see women and children.
Which facility is that one?
Sumwatachera Royal Center under Zambia district.
Oh, Rural Health Center. Thank you very much for coming. I've
you.
seen a hand from Inutu.
Thank you so much. From Luingu, we usually see women, more women than men.
You said Luingu?
Yes, Luingu District Hospital.
Thank you very much, Luingu, for joining us. I remember I like the road that goes to Luingu from Rapula. It's a great road. I like it. Chijika?
Yes, Doc. Good afternoon, everyone. I think for Batoka, we see most of the women and children than men.
Maybe I will change the question. Is there a facility which sees more men than women? Ruth Kapia.
Or we can add the question.
Yes, Doc, we see more women than men.
You see more women than
Yes, this is Mwese district, Mwese stage 2.
okay.
What could be the reason why most of the facilities, they see more women than men?
From your experience, Ruth?
I think for men, they wait until their medical conditions are in the last stage. And generally, men are stubborn when it comes to health.
You are going to raise World War III, Madam Kapia.
Okay.
Okay, the last one, Madaiso Zulu. You've raised your hands. Go ahead.
Representing Mumbai District Hospital.
Which hospital?
Here, Mumbai District Hospital.
Okay.
Yes, we usually attend to women and children.
Okay. Thank you very much, network. Indeed, I think as who are found in the facilities, I think you find that most of the facilities, whether it's in the OPD or it's in the RT or what, I think mostly on the average, we have more females at the facilities than men. And I think for this presentation today, I think that is what we want to address. Why is it that men are nowhere to be found in the facilities? Because I think if we had more time, we are going to ask another question. Most of the clinics, most of the facilities, they have what they are calling family planning days. And in during those family planning days, how many men attend those family planning clinics, the family planning clinics? Very few. I think that's what we'll be able to get. So we want to see, where Zambia has made some great progress in terms of scaling up our ART. And most of the people have been put on ART, but of course, there is a significant gap which has been found, which is affecting in terms of agenda and the age. Most of the gap has been found in the HIV testing, and also people knowing their status and also linkage into treatment. And this gap has been noted mostly in men and the adolescents, the young boys. So compared to women, men are really lagging behind in the same age group, and the health outcome are worse in men compared to women, meaning that sometimes even policy makers or health providers, they give little attention to men's services. So we can say that as Zambian men, hope the network will agree with me, that Zambian men have generally poor health-seeking behaviors.
I think it's coming from a man, so
Because
no one will argue.
So you can't argue since I'm a man. I like that. And they are less likely, like women, to engage in health services across the HIV cascade, as we have heard, starting from Luwingu, Batoka, Georgie, all these other areas, you discover that mostly people are found at the facility are women and children. And this has got an adverse clinical outcome for many preventable illnesses, because as you have rightly said, men would like to wait to come to the hospital. And in addition to this, the health system will miss a key opportunity or a golden opportunity to engage with men, especially those men who come to seek health services, by not offering them comprehensive and integrated services so that they are able to be able to receive that assistance. For instance, when a man comes, maybe has injured himself at his working place, when they come, we just concentrate on that injury which they present themselves with. And instead of us to start now screening them for other illnesses like HIV, you discover that we miss that golden opportunity. And when you look at the national HIV program gaps, I'm not going to spend a lot of time because this information is in the public domain. As a program, we have been looking forward to reduce the HIV incidence to at least less than 18,000, which up to now, we are still struggling. And when you look at this, because there's been a lot of some of the preventive measures we have put in place, really we have got low uptake of maybe PrEP and other coordination issues within the key players in the field of HIV. And of course, other reduced HIV-related mortality rates, you discover that there is, instead of reducing the mortality rate related to HIV to less than 5,000, we are still, I think, fighting for this. And the issues of also stigma. And this is an extract from one of the programs, I think the Achieve programs, which was talking about the issues of HTS. And when you look at this, you look at men from the age of 15 to 49, compared to the women in the same age group, you discover that few men know their status compared to the females. But when you look in the same age group, you discover that in terms of positivity rates, the men are higher than the women. So we really have got a lot of work to make sure that this population, this other gender, as the men are brought to the facility. And I think this explains why men are nowhere. I think this the cycle, the HIV transmission cycle, where a man is at the center of the transmission cycle. When you look at these old men, maybe you look at a man from the age of 25, maybe say to 40 or 49, you discover that when you look at the HIV prevalence rate, it is around 40%. But look at the younger women and the older women. The younger women, starting from 25 going down, it is around 22%. When you go to the older women, 25 and above, it's around 60%. Now you discover that it is this man who is able now to interact both with the younger women and the older women. So the man is at the center of the transmission cycle. And we have to break this cycle in order for us to reach epidemic control. That is just an extract from the HD, and then it shows about the HIV mortality and the sex. And when you look at that, you will discover that men are also leading in terms of HIV mortality, meaning that HIV-related deaths are more in male than in female, despite that most of the females are HIV infected. So there is not only need to find men, but there is need to treat men too. Therefore, when you look at the data from UNAIDS and the PEPFAR programs around the world, shows that really we have a lot of work to reach out to men who are at risk, particularly those age groups, which are really more like productive age groups, so that we reach them out with HIV treatments and services. Because this is endangering the men's own health and helping them to fuel the spread of HIV among the elderly women and the younger women, the adolescents. These are the same men. And I think you have heard that it is in the public domain, the issue of the sweet 16, that a man can go with anyone below his age. So meaning he can go out with his peers. If I'm 50, I'll go out with my fellow 50s, then I can still go back down to the sweet 16. So the men are more like really, they are more like delivery vans, whereby they enjoy the elder women and the younger ones. So when you look at among people living with HIV/AIDS, starting from the age of 15 and older globally, the knowledge of HIV status, treatment covered and virus status in 2018 was inconsiderably lower for men compared to women. And we can't reach epidemic control if we can't find men. Hence, we are talking about the men's health, the men's clinic. So epidemic control will only be achieved if we address these gaps we are having. Right now, the HIV program, we are talking about a gap in the men finding men, the adolescents, and the pediatrics. So we want to make sure that we close up these gaps.
Okay, great. Thank you so much. I've always known you to be very passionate about finding men. I think I'm hoping this passion spreads across the country. So dear network, we now want to engage you a bit more. So we will share some poll questions that I would like you to participate in. I just want to see what you think. What are some of the vices that put men at high risk of worse health outcomes compared to men? Pick what is applicable compared to women, sorry. What are some of the vices that put men at high risk of worse outcomes compared to women? Tick what is applicable. Which one do you think is correct here? Smoking, risky drinking, multiple sexual partners, or having a lot of money?
Look at that.
What do we think? So just tick what is applicable. Okay, so we'll end the poll. So most people went for C, multiple sexual partners. So we'll discuss in details.
Thank you. Thank you very much. I think for those answers, I know most of the people I've gone for men tend to have multiple partners. I think you'll be able to see which is really true and other reasons. So men are less likely than women to use health services when they are sick. They tend to seek medical attention when they are really sick. So a man, when he's sick, the first thing which will come in his mind is, I think I'm okay. It's either I would go to a cantemba, to a pharmacy and buy myself. If it's a headache, you won't even understand what is making that headache. It's better he buys maybe a Panadol somewhere. And the issues of smoking and risk drinking are some of the vices that put men at high risk of worse health outcomes compared to women. And also more men report having multiple sexual partners than women, which puts them at a greater risk of high infection. And you discover that when us men we are discussing, when we are discussing, you want to know that, me, I'm able to have more sexual partners than, than my friend. So we tend to compete in that area. And this puts us at a high risk. And that's why when it comes to other issues which we'll discuss about index, we feel that because of this, which is in men, when you want to get the sexual partners, you can't get just one sexual partners. And also poor OPD attendance results in low screening in men for HIV.
So the next core question is TB is leading cause of death among men, accounting for 57% of all TB deaths recorded. Is this a correct statement or is it a true statement or false? TB is the leading cause of death among men, accounting for 57% of all TB deaths recorded. True or false? Let's pick which one is the correct answer here. So far, we have 52% of the participants having managed to poll. Okay, so we'll give you about 10 more seconds before we can end the poll. Okay, I'll end the poll. So, Dr. Zulu?
Yes, truly, for these 4 questions, the answer is true. TB is one of the leading causes of death among men. And the 57% of all the TB deaths which have been recorded, these have been, of course, a leading cause of death in men. So you discover that when men are above the age of about 45 and older than that, a lot of NCDs starts coming in. They start becoming so much aware about what they are eating and some of their heart conditions, which are also a leading cause of death in men. So NCDs start really, now dawning on in men. And meanwhile, these can be preventable, but men can't go to the facility. So we are still asking ourselves, why men? And more than a third of men who have sex with men have reported to have sexually transmitted diseases. That is STIs, they have some symptoms. And TB is one of the causes of death in men. And that's why for me, instead of just looking at the 395, we add in men the 4th 95, the TPT, so that we are able to prevent our men. Therefore, since men have poor health-seeking behaviors from time immemorial, and this has impacted negatively on the fight against HIV. And men, as I said earlier on, they are likened to delivery boys. Those pizza boys whom you can call wherever you are, whether you are in Chibodia, you are in Kabronga, you are in Matelo, you are able to call them to deliver the pizza. So men are likened to delivery boys that move the HIV virus from place to place, as we were able to see from that pool question. So even though men are less likely to use the existing health facility-based HIV services, they account for a significant proportion of the new infection, which are now able to be transmitted to other women. So providing male-friendly services is an important step in trying to reach out to more men and break this transmission services cycle. So as we talk about the male-friendly services, I know one of the experts who's on call will be able to elaborate and talk more about these services, which will be attractive to men, so that we can break the transmission cycle.
Great, thank you so much. Another opportunity to interact with the network. For question number 3. What are some of the reasons why men don't go to the clinic even when they are sick? Tick all that apply. Long waiting time due to heavily congested facilities, stigma, and bad attitudes from healthcare workers, long distance to health facility, lack of male-specific services and providers. So here you tick all that applicable. What are some of the reasons why men don't go to the clinic even when they are sick? Long waiting time due to heavily congested facilities, stigma and bad attitude from healthcare workers, long distance to the health facility, lack of male-specific services and providers. These are very interesting questions, eh? So which ones here? We will give you some 10 seconds. Even ladies are allowed to pour. I'm sure you must have heard the men complaining with one of these reasons. Okay. All right. Thank you very much for participating. We'll end the poll. So, Dr. Zulu, you can have a look here.
Yes.
It's a waste of time. It's taking too much time.
Yeah, so I think those are some of the reasons which have really been, it's very interesting to know that lack of male-specific services and long waiting time are really coming out so much. But anyway, for the purpose of our presentation this afternoon, all those are some of the drivers and contributors to why men's health-seeking behavior cannot be compared to women. So one of it, of course, after, of course, the affirmative research shows that long waiting time, men are not patient. We are not patient because the facilities are so heavily congested. You discover that when you go to the facility as a man, and maybe on a typical day, I'll give an example of Kanyama, maybe where you have more like Serrari, you reach there, find that the facility is heavily congested. You would rather receive a call on your own and leave the facility than to start waiting. It's only men who are able to receive a call without anyone calling them so that they can find an excuse of leaving the facility. So usually that has affected their health-seeking behaviors. And also another reason is that, there is lack of male-specific services. We don't have people who can attend to our issues because you'll be able to appreciate that when a man is about 40 and above, you start becoming so much aware about his sexuality. So even issues of erectile dysfunctions, issues of maybe, issues of maybe prostate cancer, you can't just discuss openly, maybe with a female provider. Even an STI, and I always tell when we go for TA, I always tell the providers that when a man comes, you are a female, then he says he has got a headache. Just know that is not a headache, he has got an STI. because of the reason of lack of male-specific services, they would like to come up with an excuse, and then you go back. The time when you come to find that there's a male provider, that's when you come and say, please come and see me, I'm not okay. So men's health-seeking behaviors really are affected. So some of these like issues of stigma, cultural of beliefs, where they say, no, you're a man, you know, the way we bring out our children, our male boys, say that, no, you don't say you are sick, eh? Be strong. So we tend to grow with that. And sometimes you say that, no, I'm busy at work. And when a man tells you that I'm busy at work, then he won't be able to go to the facility. So economical situation and business schedules makes them not to go to the facility. There are few, of course, those who come and tell you that, yes, there's a long distance, I can't go to the facility, it's very far. Some of them, they'll just say, no, I can't go to that health facility because my nephew's wife works there, so I'll be exposed. Some of them will just tell you that, no, there is no confidentiality. The place is not confidential, so I can't go that side. So those are some of the reasons why men don't go to the facility.
Very interesting reasons.
Exactly. So now, what are some of the special considerations which we need to use in order for us to reach out to men? Now, from what we were just talking about, which are drivers, or we can call them barriers or reasons why men don't go to the facility, we need to understand these barriers and drivers. If you can't understand who a man is, you won't be able to reach out to them. You need to understand these barriers, understand the men who are not currently reached. When you know that, then you'll be able to come up with interventions to address the issues which are affecting them. And I think from some of the answers which were coming from the network, we are able to see that one of it is that men are supposed to be provided with male-specific services. And other issues of, the facilities are so congested. So from there, you start now thinking what you can use. So drawing upon existing research to understand your target audience and use validated results from some of the promising practices in order to inform the rightful steps of the HIV clinical cascade. And of course, we continue identifying and evaluating some of the practices in order for us to be able to reach out to men. And the issues like, for instance, when you are counseling men, you need really to revise the way you counsel men so that they feel that they are safe, they are comfortable where they are being counseled from. Therefore, what are some of the other special considerations? We are saying that we need to integrate these finding men efforts into our ongoing strategies in reaching epidemic control. Because if we don't integrate, we might miss it out. I'll give you, we have some of the good strategies like the VMMC. Integrate the finding men efforts into the VMMC so that you are able to reach epidemic control. Consider setting up some specific targets at each site, focusing on the gap. For instance, if our gap is men, the adolescents, so consider coming up some specific targets which at the site so that you target to close up that gap. And also community engagement is very, very important. Engage the community leaders, the traditional leaders, the civic leaders, the religious leaders, some civil societies. We need to engage them. And of course, recruit your community-based volunteers or counselors with knowledge of social and geographical terrain of your community. And of course, the issue of scaling up the index testing services, we always refer and we give credit to the DAP model. And of course, know your hotspot for research testing. Learning from the region, I'll talk about, I think, just two about the Marawan, where they were able to address the barriers to HIV and treatment for men, and also maybe the other one for Uganda. So in Malawi, I think they identified key barriers for men for them not to access the HIV care and treatment. So some of the barriers which they identified were hours of service. they said, you know, the facilities were congested the way we have identified. There were long waiting hours, and you know, the delivery of the service, it wasn't just easy. So, and of course, they had to identify the issues of stigma and the need for privacy. And also they said there was insufficient information of HIV. And these are some of the solutions that they started now scheduling what they were calling the male-friendly clinics days to increase uptake of provider-initiated testing and counseling, and also link it to other HIV services. They also provided services, what we were calling the extended hours, so which were suitable for the men. But sometimes in some of the typical villages, men knock off maybe around 17 hours, or maybe you're in the farming block, they knock off at around 17 hours. So they can't go to the clinic because the facility is closing up. So you need to provide what we're calling the flex hours or extended hours. And also now they started conducting targeted demand creation for community testing. In Uganda, the Project Search implemented a community campaign which offered the multi-disease screening and for HIV/AIDS. So they also came up with what they were calling the male-specific services and the male-specific mobilization activities. These, they were targeting at men, and they were able to meet the objective of the project.
This is the final poll. So on this one, says men's clinic and community posts are the two strategies identified as the most efficient at reaching to men. True or false? Very interesting question. So dear network, please do take your opportunity to poll and pick which one is correct here. Only have about 10 seconds remaining. Okay. Thank you very much. We'll end the poll. Most people think it's true, sir.
Thank you very much. Lily, you are very much right. For this question, the answer is true. Before that. Okay, so I think you are very much right. So strategies which have been found to be able to identify, to improve case finding in men. One of which, of course, there are two strategies: the establishment of the community post and also the men's clinic. So the establishment of the community post, so that it's able to increase the number of men accessing our services at that level, because community posts are established in the community where men are able to easily access without the issue of distance. And of course, I'll talk about the community post, also the establishment of the men's clinic at the health facility to offer male-friendly health services. And of course, the issue of intensifying the advanced HIV disease. Now, AHD is being done in the men's clinic, and of course, the other screening can be done also in the community post. And of course, the development of an M&E program so that we're able to track this. So the decision of combining these two was done so that we are able to respond to some challenges which men were having. So for instance, the men's clinic, this is based at the health facility. Of course, to be able to respond to the gap which is there in the men and the adolescents. And this is preferably operated by male trained staff. If there are no spaces, of course, there are some other requirements, you are able to do what we are calling the fast tracking of these boys and men for the provision of their services. And of course, we are using now the men's clinic as part of the DSD-SI or the DSD model, whereby now we are able to offer the HIV testing, test and start to put where we're able to monitor people in the HIV, for HIV care and provision of other male specific issues like VMMC, EDs, male infertility, and prostate cancer. And the community post, as I said, is one of the models which is easily accessible because this is not labeled. It is right in the community, in the bus stop, in the market, where us men who are like Nicodemus can easily go there because we like everything to be in secret. So we are able to receive our decentralized services there. So this has really worked out. And actually we were just looking at some of the data, which is showing that the community post is having a lot of tests for HIV in men compared as a facility for men. So really the impact is there. So this is also part and parcel of the DSD model. So that is just an example. Those who are in Chongwe, that is Chongwe Men's Clinic. This is the inside and the outside there. So this is designed literally to offer services to men who are in their own environment, which is conducive. Now, how do we operationalize the Finding Men initiative? Of course, we need to identify sites where men are likely to be found. And I think whether it's a community post, it's a men's clinic. Also, you need to engage stakeholders, both at the facility and in the community. We need to sensitize them. You need to bring in the neighborhood, the neighborhood health committees, the facility staff, the community leaders, and all the gatekeepers together and adopt a model which will be used by the facility. So it's not something which you decide from Lusaka to say, you starting out the men's clinic, you starting the community post. No, this is supposed to be done at that level, at the facility level, with everyone being involved. And then we'll come in to help in building the capacity for staff to be able to handle male-specific problems, to handle all these other things, because there will be integrated services which will be offered. And of course, we need to do community demand creation through various means of mass communication, mass media, IC materials developed, and other things. And then we'll continue giving the technical support and mentorship to all those interventions. What is our take-home message before the experts can come in? One, we are seeking that we are looking forward to see an improvement in the men's health-seeking behaviors. All those reasons which make men not to come to the facility. We want to see that there is an improvement, and we have a number of men who are going to receive treatment and support services as a comprehensive within their location, which is more accessible. And we want to strengthen the capacity of the health system to provide quality and appropriate and preventive care for men. For men, we talk about combined prevention, the usage of PrEP and condoms and other issues, of course. So this is some of the take-home messages.
Thank you very much for the work, for this wonderful work that was put in to put this together. And I do hope the network has picked out quite some important lessons. Yeah, thank you very much. So we'll quickly, before we get to the questions, just running through the poll questions, I think you can speak to this quickly. I know that we didn't activate the multiple choice option, but I think we'll just go as to the one which was commonly best selected. Like this one, what are some of the vices that put men at high risk of worse health outcomes compared to women? Dr. Zulu, on this one?
Yes, so we, all of you, I totally agree with you. We said, you know, men tend to have multiple sexual partners. And of course, the issues of risk drinking. When a man is drunk, it's very difficult to negotiate for safer sex. So also it puts them at higher risk. And because of the issues of NCDs, which I mentioned, also the smoking puts them at higher risk. Dr. Surumbe will tell you that even a lot of money, but I think for us, we will remain with the other three. Thank you.
Even a lot of money. So I'll start avoiding money. This one here, Dr. Zulu, TB.
Yeah, so TB, you are all correct. It's true. TB is one of the leading causes of death in men, because out of the people who have died out of TB, 57% are men. This is data which is in the public.
Okay. Then this other one here is another interesting one. What are some of the reasons why men don't go to the clinic even when they are sick?
Yeah, so as we had looked at earlier on, of course, men present themselves very late at the facility. And actually the reason, all the 4 reasons are right. And of course, being, I think the leading ones are the long waiting time and the lack of male-specific services. Men don't like to wait for services. And I think even me as a man, especially even at the bank, I don't like waiting.
Even at the bank?
Even at the bank, I would rather, you know, just operate virtually than for me to start waiting. Yeah.
Okay. And then this one here, I think you did emphasize quite a bit on this one. So thank you very much, Network, for participating. This has been a great session. At this time, I'll allow for questions from the network before we can hear from the experts also to put in, to give their inputs. So just some comments here saying that women of nowadays drink and smoke more than men. I'm sure that's just a comment. And we have another comment here, says, our men's clinic are more inclined to HIV services, especially HTS. My suggestion is to expand men's clinics to sexual and reproductive health, coupled with NCD prevention and treatment. And I think we'll hear some comments from some of the experts on the call, just to speak to this. Yeah, I've seen Mngomba has raised a hand. Please go ahead and make a comment.
Thank you very much, Dr. Ziambo. Thank you, Dr. Zulu, for this great presentation. We've seen that male participation in MCH, it is quite very low. We do not have good male involvement in MCH. And looking at certain areas of Lusaka where we have a good number of deliveries, actually having a good attendance in the postnatal and antenatal. What can we put up as a strategy to also improve the health-seeking behavior of men in that area? What can we put up in place based on what you've presented? Thank you.
Yes, before you you respond, maybe we can hear from Nathan Sinyango as well. Nathan, go ahead.
Okay, thank you very much, Doc. Sorry, the host was not allowing participants to unmute them, so hope I'm clear.
You go ahead, we can hear you. Nathan, we can hear you, go ahead.
you've also noticed, yeah, even as we do the HIV positive data audit, I think about actually 45% of children that seroconvert for HIV, actually there's no for their partners actually. So it's a very low attendance, and as a result, it's really a concern. So just to reiterate what really can be done to involve men,
We missed some
especially
of
for
what you
MC.
said.
Hello?
You're breaking, so we missed some of what you said. You said, what you say about the, following your comment about the children that seroconvert, about 40-something% of children seroconvert. From there, we missed what you said.
Hello, am I clear now?
You
Hello?
can go ahead.
Yes, I was saying that about 45% they do not have a man accompanying them for MCH. As a result, it's an unknown status. The husbands do not come along. So just trying to add on what Dr. Muwamba said. So what can be done to actually strengthen male involvement in MCH? We see this gap even as we see children seroconverting for HIV. Thank you. Hope I was clear.
Thank you very much. There you go, Dr. Zulu. I think we're even bearing into another subject matter now.
Yes. Anyway, thank you very much. Yeah, the issue of male involvement, and I think that's one of also my passions, because men are absent landlords. I call them absent landlords, in the sense that most of the women, as they go for the antenatal, especially the first antenatal booking, where it requires that the spouse has to escort them, but they are nowhere to be seen, and very few would escort their spouses for postnatal. So we really need to come up with a strategy. And I think the men's clinic, where you are either using the fast tracking or the standalone, these will be able to assist us to respond to poor male involvement. Because I think the reasons are the same. Men don't like to go to the facility. And as they have said, as the network has observed, very true, most of the status of the spouses, the male spouses, are unknown. Hence, children are being born, but their fathers are nowhere to be seen. So we really need to roll out. I wish if Mackenzie RZ was on call. I think it's one of the facility which has really improved the male involvement because of the intervention they are doing. Okay. And I think other colleagues are able to add from the call.
So any of our experts can come in and just air some comments there as well, before we ask Violet.
Good afternoon, Doc. This is Dr. Zulu. So just to add on to the question, or rather to try and answer the question that Dr. Muwamba presented, and to add on to what Dr. Olu has mentioned, one of the initiatives that we are implementing on a pilot basis for us to improve case writing among men is we're issuing out invitation slips to pregnant women. So the pregnant and breastfeeding women are given these invitation slips to give to their partners. And the slip discusses the need for the woman's partner to accompany the woman on her next visit, for example. And so it doesn't really emphasize on HIV testing per se as a major reason, but infuses it as one of the reasons why, one of the things that they're going to learn about as they come to the health facility. And it also talks about how the husband can be taught on how to take care of the woman during pregnancy, and then also after pregnancy, how they're able to take care of their baby. It puts in a lot of things to the health facility. So we're still piloting this. Thank you.
Very, very, very important comment there, Dr. Nsombo. We really appreciate you coming in and just shedding more light on some of the interventions that are working in actually male involvement in that space. Before I get back, yes, Dr. Mwanza, you're ready to say a few words as well.
Okay, thanks. In addition to what has been said, we know that male involvement has been a challenge in MCH. Of course, we have been using MCH as an entry point to bring the men, but to address and improve male involvement, we will need multiple approaches that promote a family-centered approach, that will look at people-centered services. And the men's clinic is one of the platforms that will help us sensitize men. And once we start discussing and addressing the issues that affect men, then the importance of male involvement to accompany their women will be emphasized. So we really need to use all our platform or all good practices that will help us achieve the male involvement, then just focusing on the MCH and trying to reach to men. And we have done that several times and it does not yield the result that we expect. So we just need now to think of other modalities on how we can reach to men so that we bring them in MCH as part of promoting the family-centered approach. So that's what I can add on what has been said. Thanks.
Thank you very much, Dr. Wamanza, for that. That it's a great opportunity just using men's health. You could actually be doing also promoting, supporting women in ANC, even in that space, since it's an opportunity we've met with them. I have a few comments here from Feluna. Says, we have since established men's clinic in the province, but the positivity uses so far are very low. Can we learn from others who are doing well in this area? Thanks. I think this is Eastern Province. They have established a few, but their positivity use have been low so far. How do they get larger positivity use? Then this is from Lusaka, Sinkonde. Most under 5 clinic like Chilenje First Level Hospital introduced fast tracking of mothers who have come with fathers, and it really helps to involve male participation in under 5 clinic. There's no queuing for couples. Another interesting strategy there. Thank you very much. And there's another very interesting proposal here by Dr. Wantula. Says the naming of MCH also seems to be to exclude men. Maternal and child health services seems to be very exclusive. And is there a way to rebrand to a more family-centered name that is more encompassing? You know how men don't like to be stigmatized as you know, I know that term is very common. We had a hand raised by one of our participants, Kunda. You addressed your hand. I don't know if you want to make your comment now.
Yes, thank you very much. Thank you very much, Dr. Kozia. Thank you, Dr. Zulu, and greetings to the network. My contribution was going to be, I think the initiative for including men in HIV care, prevention, care, and treatment is, I think, a good one, because at the end of the day, we had so many interventions for women, and we ended up leaving the man behind. But I think lack of a better term, be babied and, you know, like negotiate with them to reduce all those factors that contribute to them not coming to the facility. We one of my comments is as we are chatting, we need to look at facilities that are poorly staffed. We need to get there and get more men come on board. And also one of the low-hanging fruit is to package the family planning clinic such that if a woman comes with the spouse, they are attended to quickly. Because one of the things that I could tell you is that men who come, who do not escort their female partners to family planning is because they don't know. So if we include them and say, if you go with your spouse, they will take care of you fast. I think they will be able to come in. So that was my comment. Thank you, Mr. Chair.
Thank you very much, Violet, for that important comment. It does actually make a lot of sense that we really get the males involved in a way. Dr. Mwamba, please go ahead and make your comment.
Thank you, Dr. Kozia, and thank you, James, for the nice presentation. Very interesting. Just want to comment and add to what has been said, to add to the comment from Dr. Bosco about the men's clinic or men's services that are HIV centered or oriented. So with the Finding Men initiative, we did take time to revise the men's health package, and for those who had the chance to be trained in the new DSD guideline, you will notice that we've added a component of integration of NCDs and sexual and reproductive health for men in the package. So, of course, the end result and the expectation is to increase case findings for HIV. But if you put up a men's clinic and the whole idea is just to test men for HIV, they will not come. And we know the attitude people has toward HIV testing. But what we're trying to do is, we've put in under that package men's health issues. I think if Dr. Silumbe is there, can comment on that, particularly urology-related issues like screening for prostate cancer, men infertilities, STIs, BPH, erectile dysfunctions, as well as a number of NCDs, mainly the diabetes, hypertension, to mention just a few. So what we expect is men who come for those services. They will come because they want to have their BP checked. They will come because they are facing, erectile dysfunction. Then in the process, we will offer an HIV test. And when we went around the provinces and districts to look at the uptake, it was quite surprising that you see that when you look at the STI registers in most facilities, there are quite a number of STI, a lot of cases of STI, people coming with such complaint. But, there is no direct link between that STI register and HIV testing being offered. HIV testing offered separately from where the STI screening is happening. So by bringing all this together and providing an integrated package to men, we are not just going to increase on case finding, but we'll be able also to tackle these other issues that men comes with and do not know where to go and who to talk to. What we also noted is even the capacity of the providers when men come with specific men-related issues. We are good at testing and treating HIV, but when it comes to sexual and reproductive issues to do with men, the capacity needed to be built, and that's what we are currently doing. And we, of course, we are not expecting remote centers to be able to manage, complicated cases, but at least to have that high index of suspicion and to know what could be the possible diagnosis and to refer the men to the next level of care in good time so that they are attended to. So it's really a comprehensive package that we are providing, and we really hope with time we'll be able to scale up this to all the facility. But as it is now, it's really promising. Thank you so much.
Thank you very much, Dr. Mwamba, for those important remarks. I don't know if you had any other feedbacks you wanted to give, Dr. Zulu, to some of the comments that were shared.
I think I would just want to encourage Madam Ferona, maybe because she talked about establishing the men's clinic, but in terms of positivity yield, says it's so much low. I think you really need to revisit your testing, because as Dr. Mamba said, we would like to use targeted testing. And looking at men, we would really want to use targeted testing so that we can find the people whom we need to find. So please make use of your screening tool, make use of your index testing. That's what I would really encourage. And thank you, Dr. Mamba. Really, our training in terms of the men's health is really integrated. And that's why we have even one of them is Dr. Silumbe, who is on this call.
All right, thank you very much. I've seen there's some ongoing discussions in the chat. From Kashweka says that Dr. Wantula is right. A more inclusive term could sound more accommodative. Dr. Kalume has already proposed a name. We should call it parents-child health. Yeah, maybe we can do a competition
for a name.
But anyway, we will not veer into that subject matter. We have to get back to the program leads at MOH. And there's a comment by Dr. Chitu. I think it's a question. Thank you for the presentation. How do we plan to handle reaching males with health services where standalone men's clinics are not feasible? We know that not everywhere will have standalone feasible clinics, but I think Dr. Mwamba here did manage to make a comment to say working late hours, doing weekends as well, will also help to get men involved. And then also reviving workplace programs in workplaces can also help reach men, as some of the additional strategies that were already piloted and done under SWAP and CHAMP.
Yeah, maybe just one addition to, I think, to what Dr. Stu was asking. We have integrated, I'll give an example of Southern Province. Southern Province, we have integrated VMMC into the men's clinic. Yes. Because one, we have already the providers who are clinicians. So what we did was to go and train them into the package of the men's health package, so that they're able to do what they're able to do, as Dr. Mwamba's explained. So it's really integration, and also we have been encouraging most of the facilities to come up with what we are calling the men's day in each week, and also the flex hours, the weekend, operating very late. So really, it's true, it's not every facility which can have a standalone. A standalone requires a lot of resources. And the other thing which you have discovered is that also the issue of human resource. So yes. That's why you need to do the fast tracking, which is using the available resources, including manpower. Thank you.
Thank you very much. Emmanuel Mamba, those are great comments. I appreciate your comments on this subject. And you agree with Dr. Mamba that we need to make our package attractive by adding prostate screening and treatment of STI. And I think what is even more interesting is we're talking about erectile dysfunction and all those issues. I've noticed that men get excited in a training setup when we start talking about those issues. So that really also helps to attract men to those services. Yeah, so the rest are just saying thank you so much, great presentation. And then also here, Charity Liawa says target churches, stations, offices where education on men's health can be discussed openly, even media, and make brochures. All those are great ideas. Dr. Sophia Msiska from Lusaka Provincial Health Office. Please go ahead and make your comments.
Thank you very much, Chair, and thank you very much for the important topic. I just wanted to make a suggestion that for those that are not able to start the men's clinic almost immediately, they could actually reserve maybe a Saturday or a Sunday for men's health clinics. That way, they will know that every last Saturday or every certain Saturday, every third Saturday of the month, we're dealing with health, men's health. So that will also help them in coming in good numbers, because they'll always know that there's a Saturday allocated for men's health, and someone can make a time for those appointments during that time. And if they need your spouse to come with you, that will also be a good time. So it could be a Saturday, it could be a Sunday, and staff can actually rearrange themselves in such a way that at least one Saturday in a month, we are dealing with men's health only, just like the way they really look after us women. They really put an emphasis on that. So I think that could also be very welcoming in the facilities that may not have this service already implemented. Thank you.
Thank you very much, Dr. Mzeska. Great, valuable additions to the discussions. Dear Network, do we have any other hands so that we can call it a day for today after a very successful presentation and discussion?
Dr. Ziambo, Dr. Hansom again. I just wanted to maybe just mention the new clinic, maybe just say one or two things about our new men's clinic. If there's a bit of time for me to do that.
Please go ahead. There's still time.
Okay, thank you so much. And thank you, Dr. Zulu, for a great presentation. So I'll just mention that as LPHO, we've been working very closely with CIDRs in implementing activities targeted at men. So we have a number of men's clinics, as has been discussed already, and most of them are attached to a health facility. But recently we opened a new men's clinic just behind Mulungushi Conference Center, and what you may call an upmarket kind of facility. And the idea was to create an environment that truly guarantees safety and privacy, knowing already how men are when it comes to privacy and all those things. And then in addition, integrate various health services. Already there's been a concern to say most of the men's clinics just really focus on HIV. So we wanted to put up a clinic that not just focuses on HIV, but integrates other health services as well. So in other words, it's a male-centered facility with an executive kind of touch, if I can call it that. And all our providers are male. And one of the innovations we considered to put in that we thought would attract men is that we put up a pool table, for example. We know that most men love to relax over a beer and a game of pool. But unfortunately, here we can't offer alcohol for obvious reasons, but at least we can offer some entertainment of some sort. And the cherry on the top is you don't even have to pay for tokens. I guess that even makes it better. And we've got a decoder, the DSTV decoder. We're just waiting to purchase a TV so that we can at least have, in addition to the pool table, we can also have, for those who want to see the news or look at anything else on DSTV, they can do that while they're waiting to be served, for example. So the services that are provided here include screening for NCDs, HIV counseling, testing and treatment, because obviously in hindsight, what we want is to increase case finding, although we will not make it as the principal focus for the clinic. We have STI and TB screening, VMMC and condom distribution, COVID-19 screening and vaccination, still important, and then urology services as well. So erectile dysfunction, prostate issues and all that. We have Dr. Silumbe, who is attached to this facility, who will be helping us with the men that will be coming and need to be seen for urological services. And then, of course, we do have general medical consultation. And then, so what we want to try out as a strategy is to put up an appointment system. Once we get enough staff. We want to put up an appointment kind of system where if you want to see, say, the urologist after the weekend, or you want to be seen after hours or maybe on the weekend, you are able to call in and make an arrangement. And then you can be seen at least a good time. If you want to be seen at 20 hours and we have staff who are available, you can be seen at that particular time. If you want to be seen by the urologist, you just need to make an appointment and that will be done for you, and you can see him at a scheduled time. Because for now, he's only scheduled for like a day or two in the week. So we're still trying to see how we can make it better. And then for visibility, we've already made some flyers. So we target activities such as, for example, when Unza was having a sports day, we went there and we distributed flyers. Whenever we hear there's an expo of some sort somewhere, we go there and we distribute our flyers. And then we are waiting to get some airtime on TV and radio as well. This should be anytime soon. And the other issue is, let me see, just a moment. So the name of the clinic, by the way, is called the Men's Hub. And this is, it was just put there for the sake of sort of invoking a certain level of curiosity. We didn't want to call it the clinic right outside, because we've already discussed how men really don't want to be, attached to going to, receive services and all that. So we called it the Men's Hub. Someone would be passing and they'll think, is this a new chill out place or what? But once they come through the main gate, there's this huge poster that really warmly welcomes them and invites them to the men's clinics.
So Dr. Hansombo, we can hear you. Okay, I don't know, we seem to have lost connection with her. But those are very great.
So inside the clinic, there is that with the Men's Hub. Hear me? Hello?
Hi, now we can hear you. I lost you for a bit.
Oh, okay. I think my connection was unstable. Okay, so yes, so maybe just the last few comments. So we're saying once they come through, at least, there's a warm poster inviting them there to the facility, and they might just come through and say, I'm already here, I might as well just go and see what's here, and then get some of the services that we're able to offer. You can even go with your wife. It's not that it's just for men. You can go with your wife, your spouse, your partner, and we'll be able to give services to anyone. But basically what we're doing is we want to increase access for men to get these services.
Yes.
Yeah, and so I'm officially inviting you. I'm officially inviting everyone, all the men, women with your husbands and partners, please come through. I can just share. Let me just share just something small for you to have an idea of how our clinic looks like. It will be very quick.
With super boosted services for men.
Yes.
We will come.
Please come. You're more than welcome. Where is it now?
Wow. Okay. It even has the
All
ambience.
right. So this is how it looks. Yes. You can just see how beautiful it looks. And this was before we even finished. So it really has the ambience of, yes, you want to get a service in this kind of place. So you're most welcome. That is all that I had to present. Thank you so much. Thank you, Doc. That's all I submit. Thank you.
Thank you very much. Thank you so much. Lusaka is busy, eh?
Yeah, we are busy actually. And thank you, Dr. Hansombo, I think for bringing this up. I know we have a TV program which is waiting, but otherwise as Lusaka, we are leading, and I think I normally challenges these other provinces. That see, Lusaka is leading, but what is happening in Lusaka, you can also do it. And I think since I'm in Lusaka, we need to lead. Thank you.
Thank you very much. Last word, maybe you can hear a last comment from Wisdom. You've raised your hand for quite a bit. Please go ahead and unmute and make your comment. Oh, drop the hand. Okay, so thank you for the chats that came through. I see that we really need to intensify social mobilization, churches, schools, and at special events. We need to just talk about this. And then Simto also says very important topic. Sometimes men take health as business as usual, but it's also good that MCs, I'm sure these are male circumcision staff are involved in providing men's health as well. From Western Province, great works there, Lusaka for that nice men's clinic. Sounds very prestigious. Yeah, it seems so, but I think it has a certain group we want to target. Yeah, so I think, thank you very much everybody for participating. You've really made this interaction very exciting. And here Dr. Mungomba says is a very good name, attractive. Men Hub is also coming than the name Men Clinic. Okay, thank you very much. It's been a great afternoon, and any last words, Dr. Zulu, you want to make?
Yes, thank you very much, Network, and we want to make sure that men increase their health-seeking behaviors so that we attend to men, because men, these are the decision makers, these are the leaders whom we have. So I think, as somebody on the network said earlier on, we have been left behind in terms of a lot of interventions, but I think when a man takes up something, he moves with it with that passion, not really meaning that we leave our women behind. We might be creating another problem, but we want really to bring the men on board and close up the gap. We are not, running away from the HIV program, because we were able to see the gap because of the HIV program. Thank you.
Thank you. Thank you very much. Thank you, Dr. Mwamba. Thank you, Dr. Wamwanza. I don't know if you have any final words you wanted to say before we close.
No, it's fine for me.
No, thank you. Thank you so much, Dr. Mono Ensemble, for coming through and just adding flavor to the discussion. We really appreciate for coming through. And we want to thank the network. Your comments have been great. Great participation. We hope you've picked up quite some things for this afternoon. So we should be able to see you next week yet again on the HIV TB Echo, when we will be. Next week is Independence Day. Apologies. I saw some people protesting that you want to eat into our holiday. So we'll see you in the next 2 weeks. That will be on 31st of October. And do have a lovely week. Bye-bye.